Assalamu alaikum. So today in today's video we're going to be talking about acute coronary syndrome, or in regards to the bigger picture, which is really chest pain, or how to approach a patient with chest pain at the level of a primary care center. Now in today's video we want to know really clinically how we want to approach a patient with chest pain. Now typically whenever a patient approaches to you with chest pain, you always want to think of the worst case scenario, and that is an ischemic type of chest pain. So we're going to think of mostly those related to the cardiovascular system. So typically when we think of chest pain, we think of a person with MI. We think of a person with pulmonary embolism. But if we exclude those, then we can look at other causes of chest pain. So when we want to think of chest pain in a patient complaining of it, we want to divide it into three systems: cardiovascular, respiratory, GIT, and you want to add it as well, musculoskeletal. Musculoskeletal could be chest pain due to trauma in the pectoral muscle, or it could be in case of GIT, specifically GERD, where they might have a heartburn. You want to exclude that by asking the patient symptoms about it. Then you go to the respiratory. There's a lot of respiratory conditions that may present with chest pain. For example, pneumothorax, for example, pulmonary effusion, and so forth. But what we want to exclude, number one, first, before we ask the patient about a couple of symptoms, what we want to exclude, number one, is the cardiovascular origin, and that is cases of acute coronary syndrome. And acute coronary syndrome is subdivided into unstable angina and myocardial infarction, whether it's elevation of ST segment or NSTEMI, regardless, myocardial infarction. And then you look at other cases such as pulmonary embolism and so forth, or perhaps pericarditis and so forth. So now let's approach chest pain بشكل عام, or in general. So regarding chest pain, whenever a patient comes to me with chest pain, he may be in a form of a stable condition, which means I can take history from him. Or classically, a patient may come to the clinic complaining of chest pain, and then he suddenly dropped on the floor. So they may go to فقد الوعي. So he fell on the floor unconscious, and now you as a physician, what are you supposed to do? So let's look at the example of a patient who comes to you with chest pain and he suddenly dropped on the floor. So in regards to that type of patient, what will you do actually clinically as a physician? Well, as a physician, what you will do start first is, if you're in the middle of a meeting with a patient, you'll ask the patient for permission. I'll tell him, I'm sorry, I have a case of an emergency. I will take permission and I need to go right now and treat this patient as if right now. So I'll take permission from the patient and I need to go immediately. Then I will look at the patient and I will tell the nurses, please send this patient to the resuscitation room, all right? In the resuscitation room, I need to take what? I need to make sure whether this patient is stable or not. So I will order vital signs, for examples, meaning blood pressure, pulse rate, temperature, and so forth. Once I take the vital signs, along with it, I will order for an ECG, which is all present, by the way, in a primary care clinic. So I will order for an ECG, I'll order first for vital signs, and if I can, I'll also order for some laboratory investigations. For example, I can order for troponin enzyme measurement, for example. So I will order all of these together once I send the patient to a resuscitation room, okay? While I'm doing all that, I'm not just gonna wait for the investigations to come to me. While I'm ordering for all of this stuff, I will do a focused examination on the patient. I'll examine his chest, I'll examine his pulse, I'll examine his lower limb, things that can help me in discovering what is wrong with the patient specifically, okay? So I will do all of that in mind whenever a patient is unconscious, okay? Now let's say, in regards to this patient, let's say that this patient, we found out that his vital signs is relatively stable, okay? And we found on his ECG, we found that in V1, in V2, we found an elevation of basically the ST segment, okay? Or let's draw it one more time. Elevation of the ST segment. If I see elevation of the ST segment in two lids, then there's suspicion that this is a case of MI, or more specifically, ST elevation myocardial infarction, okay? So what if I get an ECG result that confirms for me MI? Khalas, this is a case of MI, I'll treat it as MI, okay? But let's say the ECG is normal. Does that mean I would consider it as normal? No. Typically when we order an ECG, you don't just order it one time and that's it. There's something known as serial ECGs. You order more than one ECG result to make sure that this result is normal or not. Because as you know, with time, ischemic changes tend to develop over a long period of time or over a couple of hours, let's just say, okay? Now that we got that out of the way, we can order an ECG and then we'll know. But a question, do I also have to wait for an ECG to treat the patient? No, I can treat the patient as of now, okay? So in the case of this patient, I'll give him certain treatment. I'll start with something what is known as MUNA, for example, okay? So in regards to MUNA, this is basically an abbreviation that stands for morphine, which is M. O is for opioids, or let's say analgesics, like for example morphine. N is for nitrates, and A is for aspirin. This is a medication I can start with, which if I can suspect that this is a case of MI, or at the very least, I can stabilize the patient, okay? But let's say we have all this in mind, all right? Let's say best case scenario, I did examination for the patient. I took the vital signs, they appear normal. On ECG, I found abnormality, and let's say I found troponin levels to be elevated. With the patient's condition, I'm suspecting this is a case of MI. The most important part is in a scenario such as this is the speed. How fast are you? You need to make sure this patient is treated and sent to the hospital. That's your goal. While waiting for the ambulance to come in, you as a physician in the primary clinic, you will treat him as of now. So you can treat him, for example, with MUNA, for example. Now MUNA is not necessarily applied to everything, okay? Like let's say for example, let's say the vital signs showed that this patient's blood pressure is 80/50, hypotensive. Then morphine isn't necessarily a good idea. Or let's say this patient, he has vital signs unstable throughout and he's unconscious. Then in that case, morphine might not be such a good idea. Same goes for the oxygen. Let's say the vital signs say that the oxygen saturation is around 96%. Is oxygen necessary in that case? No, you don't have to give oxygen. But what about, let's say this patient is hypotensive. Again, you don't have to give nitrates because nitrates can further drop the blood pressure. You don't want to go into another complication such as shock. But let's say in the case of aspirin, let's say this patient, if I know he has a history of bleeding, okay? He has a history of bleeding from like peptic ulcer disease or whatever. Then, in that case, aspirin is not recommended because aspirin can exacerbate the risk of bleeding, being an antiplatelet agent. So I can give, instead of aspirin, clopidogrel, okay? Now, clopidogrel is his brother, but even in the case of clopidogrel, I don't have to necessarily give it if I don't see signs of ischemia on an ECG. For example, signs of ischemia was one of them, was an ST elevation, but they can appear as other signs as well. For example, you can have a T wave inversion, for example, or you can have a PR interval being prolonged, for example, or you can have what is known as a deep Q wave, like this. You're like an inverted QRS, but deep. Okay, so these are other signs of ischemia that you might see in ECG, not specific to MI, in general, that might lead to you that, okay, I can give this patient clopidogrel, okay? So what I want you to keep in mind is MUNA is typically seen as first line, but it's not necessarily applied to every single case, all right? Not necessarily that every case we have to give this patient aspirin 300 milligram tablet, or we have to give him morphine. Like especially, let's say this patient has inferior MI. You give him meperidine instead of morphine, so it doesn't cause further bradycardia, because bradycardia is associated with inferior MI, for example. So that's what we want to keep in mind as well. So let's summarize that case. Let's say a patient came to you unconscious with chest pain. First, like we said before, you want to excuse yourself from your current patient. This is the case of an ambulance. Then you run, like Sonic. You run away to the patient. You order this patient goes to the resuscitation room. And then afterwards, you will assess the patient. You will ask for vital signs. You will do examination, quick examination on the patient, checking the pulse and cardiovascular examination and so forth. Then you'll order for an ECG. Then you'll order for troponin levels if you can. And then after that, don't forget to call the ambulance. You have to keep in contact with the ambulance, tell them about the case, bring them in. And then that patient, eventually with the ambulance coming in, you will treat him as you're waiting for the ambulance. Once the ambulance come in, the patient goes to the ambulance to the nearby hospital, and you yourself, the doctor, will come with him. You will join with him in the ambulance to help with whatever. Like let's say this patient has cardiac arrest, then you'll have to do defibrillation, or you're gonna have to use defibrillator, or whatever they use to kickstart the heart, okay? And then you will come in contact with the other providers, keep in contact with them, help them in their case. What does he have exactly that we need to know regarding his treatment, okay? So that's something to keep in mind as well. And then there's other drugs as well. Some doctors say if we have a case of chest pain, we might at this point administer beta blocker, we might administer any heart failure drug, but the most important is you want to stabilize the patient first. The patient has to be saved before anything else, okay? And let's say, for example, we stabilize the patient, right? He's in the hospital. What do we do next? In a case of MI, let's say, then in that case, you have to decide according to the time. Are you going to do PCI, which is percutaneous coronary intervention? This is what they do for MI. Or are you going to do thrombolysis? And this is according to the time at that point, okay? So this is how you want to approach a patient who, let's say, is essentially unconscious to you, okay? Now let's say this patient has chest pain, but he's relatively stable. He's able to come to you to the clinic, and you're able to take a comprehensive history from him. Then in that case, you now start to think of, okay, is this a case of an ischemic chest pain or something else, all right? So like we said, chest pain could be cardiovascular, GIT, respiratory, but we're gonna focus on the cardiovascular because we want to assume any chest pain to be ischemic until otherwise, okay? Now, whenever we have a history of a chest pain, like an MI, patient will come to you with left-sided chest pain, right? And it's crushing-like, and it's sudden, and at times it is exacerbated with activity and relieved with rest. And in severe cases, it may be radiated to the entire left side of the body, and there's sweating, and maybe pain in the legs. With all of them symptoms in mind, you will think of MI. Sometimes in some patients with MI, they might have a family history of MI. Some of their first-degree relatives, they might have had MI and died at a young age. For example, their father died of an MI at the age of 35, for example. So that gives you an idea that most likely this can be a case of MI. But can I diagnose MI just clinically through history? No. You have to do a couple of confirmatory tests. Even in cases such as pulmonary embolism, if a patient came to you with chest pain that exacerbates with breathing, and he has hemoptysis, coughing with blood, and he has shortness of breath, and he tells you he had a history of swelling in one of his legs, along with pain in one of his legs, specifically his calf muscles, and he had a history of immobilization. Even still, even if you suspect pulmonary embolism, you have to do confirmatory tests for that as well, okay? And regardless of your history, with a cardiovascular case, suggesting this is ischemic or not, then after that point, you go through examination. If you exclude ischemic chest pain from history, then you go through other causes of chest pain. Is this GERD? So you ask about heartburn, difficulty in swallowing, regurgitation, and so forth, and respiratory cases, and so forth, okay? Then you go through examination, and then from that point on, you will decide which investigations you will order, all right? So let's go through each of these steps. We already talked about definition. Acute coronary syndrome is basically a syndrome that, like we said, it varies from unstable angina, meaning it's like stable angina, but you have pain even at rest, to MIs, and we talked about the definition of it. We also talked about the clinical features, really, about a lot of this stuff. We also talked in general how we will diagnose this case. We will diagnose it through history, through examination, and through investigations. The investigations, as we said, we're going to do with ECG. We're going to do with laboratory investigations, so we're going to say specifically troponin, all right? And in some cases like pulmonary embolism, you might do pulmonary angiograph. But let's look at specifically MI, shall we? Let's say I'm suspecting MI, then in that case, I have to do ECG and troponin. ECG is not necessarily a confirmatory test. No, it might appear normal, it might appear abnormal, all right? If it's normal, repeat the test again to be sure. If it's abnormal, then in that case, it might give you an indication this is MI. Let's say you have an ST elevation, right? Or an inverted T wave or signs of ischemia. there's a high chance this is MI, but this will not guarantee that this is 100% MI. That's why in cases of MI, you will do ECG plus troponin. Now, troponin is one of the cardiac enzymes, and it is basically an enzyme that is secreted as a serum or secreted into the bloodstream whenever there's damage to the heart. So in the case of MI, of course, there's going to be damage to the heart. So troponin levels will elevate as a result. And in the case of troponin, the same concept is ECG. In the case of troponin, we have to do more than one test. Okay? If we have troponin levels normal, one-time measurement, we have to do it again, serial troponin. Okay? Now let's say the troponin level is 15 nanogram. All right? Let's say it's 50 nanogram or more. If I see this elevated levels of troponin up to this number or high more than once, then this can confirm for me that this is a case of MI. And whether it's a case of STEMI or non-STEMI, I will know from the ECG. Okay? So this will confirm for me in general MI. So troponin and ECG, I have to have more than one reading, 2 readings max per each. Now we have confirmed for us also case of MI. But a question, Nawaf, is troponin considered confirmatory lil MI? No, not necessarily. Like we said, in ECG, there can be changes that are not specific to MI. It can be changes that are relative to numerous of cardiovascular conditions. And the same goes for troponin. Troponin, if it's elevated, that does not necessarily mean that it's MI. It could be related to kidney diseases, could be related to ventricular tachycardia, it could be related to other things. So that's why you cannot rely on just troponin, and you cannot just rely on ECG. You have to rely on your history, on your exam, on your ECG, and your troponin all together to confirm that this patient has a case of MI. In the case of pulmonary embolism, you have to confirm with pulmonary angiogram, all right? So that's how you finish with the case. Now, what about the treatment of MI? How do I treat a case of MI? Simply put, you treat it with what you took for previous MI. First, you stabilize the patient, and then you do your surgery, whether PCI or thrombolytic therapy, according to the time. Once you stabilize the patient and you got rid of the problem in the coronary artery, whether it's a thrombus or atherosclerosis, next, you need to prevent another case of MI from happening ever again. So this will depend on the patient. Typically, in most cases, you'll give this patient beta blocker post-MI, or more commonly, you can give this patient ACE inhibitors, for example. And in most cases, as secondary prevention, infamously, you can give this patient aspirin, all right, or nitrates, or digoxin, according to the cause. So it's according to the guidelines and according to the patient case, what medications you will give this patient post-MI as secondary prevention to prevent another case. And the ideas behind these medications is that you want to have less load on the heart. You don't want the heart to be inactive, but you don't want to overwork the heart now that it's been damaged from previous attack of MI, all right? So that's regarding the treatment. And of course, there is also, like we said, guidelines, and there's a scoring system. They have a scoring system that basically decides whether this patient is at low risk of another MI, medium risk, high risk. I'll not go into detail, but the idea is that the treatment, like we said, depends on the patient's case, depends on the guidelines and the scoring system, whichever you use in your hospital. Regardless, medications will be given to the patient to prevent another case of MI, and that will determine the prognosis. All right, that will determine the prognosis. Also, as you know, before cases of MI, they might have something known as risk of ASCAVID or risk of MI. They have a whole numerous bunch of risks that they calculate. They look at the patient's blood pressure from now on, his blood lipid levels, his age, his gender, and his also if he's able to smoke or not, smoking for long periods or not. All of these are added in calculations to determine whether he has another risk of MI, and if he has a risk of MI high, then we will adjust the medications accordingly. Okay? Now we finish the case of acute coronary syndrome. The one last thing I want to mention is specifically the ECG findings, and that will be in another video. Thank you very much.